From the California State Senate, this is Senate Spotlight.
Hello, everyone, and welcome to this segment of Senate Spotlight, where we discuss legislative priorities, policies, and other related issues with members of the California State Senate. From the state capitol here in Sacramento, I'm Brian Green, and joining us this time around is State Senator Bill Monning, representing the 17th Senate District along California's gorgeous Central Coast, including Carmel and Monterey and all of those areas. He is the Senate Majority Leader here in the California State Senate and also Chair of the Senate Legislative Ethics Committee. Welcome, Senator. It's really glad to have you.
Thank you, Brian. It's a pleasure to be here. Appreciate the opportunity.
Always. And I mentioned you were the Chair of the Legislative Ethics Committee, and this is a very awkward little segue. So we're going to get right into this, talking about a ethics issue here in California and here in the legislature that's certainly one of the most contentious this year, if not in a while, and that is your SB 128, the End of Life Option Act here in California. And it's legal in 5 states. You and your principal co-author, Senator Lois Wolk, have said California is ready for this law. We've tried this before. We have failed. Why now? What's the difference now?
Well, I think the biggest change since about 10 years ago, 2006, when it was last introduced in the State Assembly, there's been a massive sea change of public opinion. As you mentioned, 5 states now recognize an end-of-life option, and public sentiment nationally and in California, it's about over 70% in support of an end-of-life option.
Why you, the advocate? Why? Obviously, it's a bill, you're carrying it. Right. You, of all people, why?
Well, you know, I've had a history as former chair of the Health Committee in the Assembly. I currently sit on the Health Committee in the Senate. My wife is a family practice physician. She's dealt with end-of-life issues. I think everybody's had a family member, a friend, a relative where we've grappled with the loss of a loved one due to a terminal illness. So I think it's a convergence of those factors. Also, I was approached by the senior legislature of California. They ranked it as their #1 priority in about 2 years ago, and had asked me to carry legislation 2 years ago. And we're in the middle of a 2-year session at the time, said let's revisit it at the start of our next session, and so here we are.
When we first want to talk about this bill, it's easy to default to sort of the glib descriptions: assisted suicide, euthanasia, aid in dying. I know this isn't about word semantics. Why the difference in calling it an End-of-Life Option Act?
Right.
What's the difference that makes the difference here?
Right. Well, I appreciate your asking that, and the semantics do matter, we believe. Often the media default has been physician-assisted suicide. Suicide has actually a very specific definition in psychiatry and psychology. It's an irrational act. We see this as part of a continuum of existing end-of-life options. It's really a compassionate choice that is only available to a person who is mentally competent, who is dealing with a terminal illness as determined by 2 different physicians. They have less than 6 months to live. So their death is preordained, not by their choice, usually by an unfortunate onset of a terminal illness for which there's no known cure, there's no treatment other than to try to relieve pain and suffering. So within those confines, we think this is appropriately seen as part of that continuum of a choice at the end of life that gives that person facing certain death the opportunity to exercise their own self-determination, their own autonomy, to pursue a compassionate transition, which, if they are eligible for this end-of-life prescription, it is a very gentle way to transition, and some people will choose this over a less certain end-of-life decline that can at times be very horrific, very painful, even with pain management, with hospice, with palliative care. There are some end-of-life scenarios that are not pleasant either for the patient or for their loved ones.
You have put plenty of safeguards and checks and balances into this, not only for the patient, but also for the doctors, for the physicians that would be involved or affected by this. Detail a few of those already.
Right. So first and foremost, this is absolutely voluntary, starting with patient choice. It cannot be exercised by a conservator. It can't be exercised by an advance directive. Only real time a patient with their doctor. The doctor can only participate in this if he or she chooses to. So it's voluntary for a physician. It's voluntary for a medical facility, like a Catholic hospital, for example, would not have to participate in this. And we have protections that protect against coercion. We have felony penalties in there if any insurance company, life insurance or health insurance, seeks to condition your coverage as to whether you use this or don't use this. In other words, they cannot influence or modify their coverage based on whether you choose to exercise this option or not. So we think those safeguards also protect physicians and pharmacists from any type of prosecution. They're immune if they participate according to the way the law is drafted.
And it's modeled after the Oregon law, and so there were safeguards there. I think there was, the number I saw was less than 800 people since the law went into effect have actually chosen this option.
Yeah.
No lawsuits, that kind of thing?
That's correct. So we do look at 17 years of experience in Oregon. I think about 1,300 people have exercised the option in Oregon. Interestingly, of the total universe of people who qualified and applied for the prescription, just under 60% have used it, meaning over 40% secured the prescription but didn't use it. And there's a story there as well, because it provides for some people peace of mind knowing that that option is there. Our hope is that hospice and palliative care and pain management are effective tools, but just having the option for some people provides peace of mind. We've also built on the Oregon protections. In California, we've included language that would require translation if the conversation between patient and doctor is in a language other than English. Then any of the paperwork that has to be filled out, the application, if you will, by the patient, would also have to be translated into that non-English language.
Earlier in the year, you had a big press conference here at the Capitol, you and Senator Wolk and your Assembly co-authors. And you had brought in a couple of different people, family members of a brain cancer patient who has made international headlines, who had moved to Oregon to end her own life, to take advantage of the law there. The father of the young girl who had suffered horribly from leukemia to her death, and then a woman who is in cancer remission but possibly facing this kind of question down the road. Obviously, this galvanized you and your colleagues. It galvanized everybody in the country who saw that footage.
Right. Well, you made reference to Brittany Maynard, who passed away on her own timetable with a terminal brain illness, but her family did have to move to Oregon, establish residency in Oregon. She was a very vital, articulate, courageous young woman, age 29, recently married, and she and her family moved to Oregon. Her mother did participate, and her husband, in the press conference that we held at the time we introduced the bill. They continue in her memory and legacy to be very active in advocating that families shouldn't have to move to Oregon. Not all California families have the means to leave jobs or establish residency in Oregon. And the fact of the matter is, in California, where this right does not exist, there are unfortunately many stories of people with a terminal illness who can legally buy a gun and end their life using a gun and leaving that trauma with loved ones and family members. So what we're saying is this isn't mandated on anybody, but for somebody who is eligible based on the requirements of our law and wants to have that option available, we think it's first and foremost a fundamental patient right, a human right, a right of self-determination and autonomy. You made reference also, Brian, to the Dr. Robert Olvera, whose daughter died of leukemia. He's a family practice physician, Harvard trained, a Vietnam veteran, Latino, Catholic, and he said at her end of life, the pain management was not effective. She was begging her father, the physician, to help her, and there was nothing he could legally do to ease that suffering. And so he's left with the image of his daughter having a very painful and horrific decline in the last week to 10 days of life. So this is an idea, I believe, whose time has come. It is a voluntary option that we seek to create, and one with, we think, sufficient safeguards and protections. And from the Oregon model, no evidence of abuse, coercion in Oregon.
Well, let's talk about some of those concerns. I know there's the safeguards and the protections in the bill, but the concerns are still out there, and that is what's sort of driving the momentum and the debate here. One of the concerns in Oregon is that there are medical ethicists who have said that, you know, this is still, doctors are still looking at this as assisted suicide. They're still calling it that. There's the patient who got his prescription in the mail and he couldn't bring himself to self-administer, so he called his brother to do it, and there were no charges. There was the story about the woman who insurance company denied her $4,000 treatment for brain cancer, but paid for her prescription for the end-of-life option. So there's still folks that say there's this slippery slope, and there's not necessarily going to be a way to ensure that these safeguards are always followed. What do you say about that?
Well, again, first and foremost, we take the concerns very seriously, and we believe that we've designed the legislation to build in those protections and safeguards, and that the benefit to be obtained by people suffering from terminal illness far outweighs speculation of possible slippery slopes. We just think the safeguards are strong. We don't believe that Oregon has evidence of violations or of coercion, etc. I would also add that on top of the, some of the opposition historically from some physicians groups, it's not monolithic. In fact, recent polling shows that a majority of physicians nationally are now supportive of this end-of-life option. There are conversations going on in California right now within the California Medical Association, within the California Academy of Family Physicians. So if nothing else, our legislation has prompted, I think, very constructive conversation, discussion, and decision-making within medical associations.
Well, your wife is a doctor. Obviously, you've had some dinner table conversation about this. How does she feel about it?
Well, she's very supportive. As a family physician, she's worked with families dealing with end-of-life issues. She's been a strong advocate for patients to fill out advance directives, most of whom don't. Our culture, we're not very good about talking about end-of-life issues, and unfortunately, very often it's at the end of life where unresolved family issues or differences come to the fore when a loved one is in their end-of-life stages. Now, again, the reminder is this goes not just to any end-of-life scenario, only end-of-life related to a terminal illness. My wife is a strong supporter. She's a member of the California Academy of Family Physicians, and that organization is currently reviewing its policy.
Now, the folks that have supported this bill, a lot of them have said this is not a religious issue, and yet there have been clergy members who have spoken out in support, saying that our God is a loving God, and he would not want to see anyone dying in pain. But let's take it even to a deeper issue, if I can. I know you're not a theologian, but you have dealt with these kind of issues, to something deeper and spiritual, that part of the fullness of life would be the suffering of it, the tribulation, and that through that experience of the suffering and death not being on our own terms, there's something richer that comes from that. And again, it's part of the discussion. I'm sure you've heard it before. What do you say to something like that?
Well, we've heard that conversation. I have engaged, I would say very respectfully, with the Catholic Church. Had a very good, enriched meeting with the Archbishop Gomez from Los Angeles. And just first and foremost, we do not seek to change Catholic doctrine. We don't seek to mandate or enforce this on any religion. To the extent Catholic churches operate hospitals, this would not mandate a physician within a Catholic hospital to participate. But we also know that polled individually, many Catholics are supportive. Now, back to your more focused philosophical point, I think there's no doctrine that is written in stone and is certainly not law in the state, and we do have a constitutional system that's built on the separation of church and state, and we have to be careful to know where that line exists in terms of civil rights versus religious doctrine. To those who believe that an end-of-life scenario that includes suffering is part of life, they're entitled to that belief. My personal belief is that we have the tools to ease suffering, that part of physician training is not only to extend life, it's also to ease pain and suffering. And we have the tools to ease pain and suffering, and there's no religious doctrine that suggests physicians in the care of a patient should not intervene to ease pain and suffering. So it's really a question of this continuum. We've established rights in California today that allow you or me with an advance directive to say do not resuscitate, when a doctor has at his or her fingertips the tools to resuscitate me after, say, a cardiac event at the end of life. But I have the legal right to say, no, I choose that you do not resuscitate. That's existing law. I have that right. So the question in that continuum then becomes, should I have the right in a conversation with my physician when I'm facing end of life based on a terminal illness to say, I also would like you to respect my right to choose my time of transition in a manner that is peaceful, that doesn't traumatize loved ones, that doesn't leave loved ones with an image of horrific intervention, of massive pain and suffering. I'm not aware of any philosophical doctrine that suggests that we are better people by subjecting loved ones to horrific pain, suffering as part of our decline.
Thank you for sharing this information. I mean, if nothing else, even this discussion shows that you have really lit the fire here. You have created a catalyst for further discussion, which again, if nothing else, that's what the state needs on this subject.
Right. Well, thank you, Brian. Again, appreciate this opportunity. Again, we don't see this bill as supplanting important conversations within the family and accessing hospice care, palliative care, pain management. We think that is part of good medical practice and good family conversation. So we do hope that that is part of what comes out of this specific legislation.
And I know we're running a little bit late, but I am going to ask you one more time. We've had a few attempts that have not been successful in this. You feeling good about, as you head to your first policy committee hearings on this, that you got the chance to get this to the governor?
Yeah, I'd say cautiously optimistic. We don't underestimate the power of some of the opposition. In the Senate, we will first go to the Health Committee, and that will be our first hurdle. Our plan is just take it a step at a time and try to share this type of information with our colleagues and committee members, and they will ultimately vote their conscience on this issue.
Great. Senator Monning, thank you so much for taking the time to talk about this. That was great.
Thank you.
Talking about SB 128, the End of Life Options Act here in California. State Senator Bill Monning of California's Central Coast, Carmel to be specific. He is also the Senate Majority Leader. And that is this edition of Senate Spotlight. That's it for us here. We join us next time around. We invite you to as we discuss important legislative issues and policies with the newsmakers and newsbreakers of the California State Senate. From the state capitol here in Sacramento, I'm Brian Green. Thanks for watching.
Thanks for watching Senate Spotlight.